what this boils down to is that the drug of choice, whether it being Percocet, Vicodin, OxyContin, fentanyl, morphine, any of those opioids, instead of taking that drug of choice, to substitute it with a less active drug. This less active drug does not induce the high or euphoria that the drugs of choice do. And so it's replacing the opioid with one of these other agonists. The agonist means that it's stimulating the same receptors that the drug of choice does. So the types of opioid replacement therapy are both one of them is the well-known historic one, which is methadone. This is a drink or a liquid that's available from a pharmacy. They mix it on site and it's available 1 dose per day. Sometimes they'll give the user, if they trust them, some carries, so the person doesn't need to come back to the pharmacy. But the other name for this is liquid handcuffs, because the person is inevitably tied to that pharmacy for quite a long period of time, because most people take months and months, if not years, to get off methadone. The other opioid replacement therapy, the newer one, is called Suboxone, and that's the trade name. The actual name is buprenorphine mixed with naloxone, which is the antidote in a very small dose. So this drug is a combination drug, Suboxone, which the idea is to substitute this instead of the drug of choice, just like with methadone. So the idea is the user stops their drug of choice, they go into withdrawal after about 24 hours, and at that point then they are dosed with the Suboxone to try to get to the appropriate dose, so that they're not getting sleepy from too much, but they're not going through withdrawal by too little. So trying to find the right dose. Now this tends to be anywhere between 4 and 24 milligrams. It's a wide dosing window. But once this person is stabilized and they're not going through withdrawal and Suboxone, now they're on this replacement therapy, and now they're no longer feeling the withdrawal, and they can get back to their normal routine in life. The idea now is to reduce it. Some physicians prescribe a rapid wean, which is what I experienced, and it's not for everybody. It's very uncomfortable, but I went through withdrawal much quicker, but I was able to get off quicker. These slow weans are the more commonly ones used, and there's less chance of relapse with these, and so just gradually 2 milligrams per dosage is reduced, but this is over a greater period of time. We're talking about several months instead of over a week. And the person can continue on the Suboxone or the Methadone for up to years. The problem, though, in the long weans is it's much harder to get off those final couple doses. So the final milligram for Suboxone is difficult for some people, and they go into withdrawal, and this is a high-risk period to relapse. Same thing goes with Methadone. If they've been on it for a long time, the final, I think it's 30 milligrams or 60 milligrams. It makes it very difficult. Where this final dose, with Methadone, they try to reduce the dose by 10% every 2 weeks. So it is a challenging time. Each one has their own challenges, but this comes down to the user themselves. Is they need to do some work here. At some point, they need to pay the piper. They need to hopefully get off the medications entirely. Some people can't do it, and they've tried several times and they relapse. But the idea is to get off of it, to bite the bullet per se, and to try to get off the final doses. So opioid replacement therapy, or medically associated therapy, or opioid agonist therapy are all the same things when it comes to the opioids. This is to substitute the drug of choice with a long-acting, less active opioid agonist, whether it being methadone or Suboxone. It allows them to function properly, so they're not going through withdrawal, so they're no longer chasing the high and chasing the drugs and spending a lot of time and energy into obtaining their drugs. It enables them to start functioning properly in society, to keep their job, and to slowly wean off these medications, or sometimes rapidly in certain cases when a person's in a rehab or detox. But that is the general purpose of this, is it helps. It's safer these ways. Also, there's lower likelihood of relapse, lower likelihood of overdose. So all these things are very helpful. And the proper term that this all falls under is something called harm reduction. So the person's still using an opioid, but we're minimizing the harm that they're causing to themselves and others, and there's nothing wrong with this. The other school of thought is total abstinence. And once I weaned off of Suboxone, that would be considered total abstinence. But that's not for everybody, because it's a high likelihood that people relapse in that situation. So to summarize again, I've already done that, but opioid replacement therapy is a good idea. It's for safety reasons, and this is something that people can obtain very easily through their family physician or even in the emergency department to get them on Suboxone. as a temporary measure to keep them safe and to continue on to get ultimate treatment, which in my view would be rehab.
We've helped over 1 million Americans completely recover from substance abuse. Call now at 1-800-615-1067. Call now.